there are three components to the initiation and maintenance of AF, and those are relevant when discussing surgical methods to address AF. So, firstly, there are multiple microcircuits in areas of, if you like, stretched and expanded atrial myocardium. There are focal drivers which may initiate abnormal rhythms, and these have mostly been found to be clustered in the muscle cuff around the pulmonary veins and also in the back wall of the left atrium. And then, perhaps in some ways most important, there are rotor sources, so basically pathways around structures within the heart which allow perpetuation of atrial fibrillation, and certainly the Mays procedure is designed to eliminate all potential rotor sources. So in addressing atrial fibrillation surgically, we're looking to isolate any focal drivers, particularly in the back wall of the heart. We're looking to block all potential electrical rotors, and at the same time, the important move is to prevent thromboembolism as far as possible. Next, please. Thank you. So there are several approaches to surgical AF ablation. I think it would be fair to say that a Cox-Maze is the gold standard surgical approach at present, and we're in the fourth iteration of Cox's Maze, which is mostly conducted with a combination of bipolar radiofrequency and cryoablation. And the Cox Maze aims not just to eliminate AF, but to aim for functional sinus rhythm, which is a distinction from some of the other approaches. A reduced approach would be pulmonary isolation alone. So if you see in the top right of the screen, there's a schematic of left atrial lesion set from a Cox Maze 4. So we have pulmonary isolation lesions around both sets of pulmonary veins. This, of course, is the surgeon's view, and it doesn't look quite as good as that. And those are created usually with a clamp across the pulmonary veins. Then you have superior and inferior connecting lesions, which are placed across the roof and floor of the left atrium. You have a lesion to the appendage, and the appendage is generally excised or obliterated. And finally, there is a lesion down to the mitral annulus, the so-called isthmus lesion. I conduct that with cryotherapy, I think many do, and most people combine it with an external lesion on the coronary sinus to prevent leaving a gap in the line there. But as I suggested, pulmonary vein isolation, just to take out the muscle cuff around the entry of the pulmonary veins, that's an approach which some would use, especially in the setting of paroxysmal AF. Another approach for which I've seen superb results is the convergent procedure, and that's shown in the lower right diagram, where basically you use this device, it's a unipolar radiofrequency, to burn the hell out of the whole of the back wall of the left atrium. And the superb data I've seen from London on that was combined with pulmonary vein isolation by catheter. So a minimal access approach. This device can be inserted through a subxiffy incision, and then you have a catheter-based pulmonary vein isolation in combination with it. So a very attractive technique, especially for isolated AF. Surgical access for a concomitant procedure may often be through a stenotomy. It is possible, and I know Donna's going to talk about this later, to do some or all of this lesion set by minimal access with VATS, or as I've already mentioned, doing the convergent through a mini access approach, and the hybrid approach is also feasible. Next slide, please. So my remit was to talk about AF ablation during the current pandemic, which is a slightly difficult topic because it hasn't changed what we would do and when we would do it very much. So concomitant AF ablation, I think we would be looking to conduct that in any clinically urgent cases which we manage to get treating. Standalone AF ablation, while I think it is a very valuable therapy, would very rarely fit into the clinically urgent category, and certainly in our unit we've done no surgical standalone ablation and very, very little catheter-based AF ablation. Next, please. So a background to AF, I won't dwell on this because I suspect similar things will appear on other slides in other talks. We know that atrial fibrillation is a very common condition. It's largely age-related, although not exclusively, but as you see from the table, in the over 75s, this is quite a predominant condition to have. Other risk factors, there's a genetic element, there are gender and racial differences, and there are some modifiable risk factors, which is really important. So sedentary lifestyle, a history of smoking, obesity, diabetes and hypertension, these all correlate with an increased incidence of AF. Next, please. Of course, the primary concern for many people with AF is the stroke risk, and we know that there is a substantial risk of stroke, and we use the CHADS-VASc score to try to quantify that risk. And this table shows the scoring system for CHADS-VASc. And you will all be well aware that before choosing to anticoagulation a patient with atrial fibrillation, we would also look at the bleeding risk, and there is another score called has bled, which I haven't put on here, but you would generally assess the stroke risk and the bleeding risk in conjunction to decide treatment for an individual patient. Could you click again, please? And here is some data from early in the use of the current CHADS-VASc score, looking at the score versus the observed stroke rate. I don't think the score was ever intended to be a one-to-one, but it's quite a close correlation, where the numbers seem to get a little aberrant down the bottom. If you look at the original paper, the numbers in these groups are really small. Okay, thank you very much. Next. When I was a medical student, and that was a long time ago, AF was considered to be a benign condition. You control the rate, think of anticoagulation. I think we're increasingly aware that AF is by no means a benign condition. I've already mentioned stroke, which is the most obvious correlate, but what is not widely appreciated is those patients having an AF-related embolic stroke have a higher in-hospital mortality than other causes of stroke and a lower chance of discharge to home than other causes of stroke. So it's a bad stroke generally. Click, thanks. There is also a bidirectional relationship between both AF and heart failure and AF and myocardial infarction. So it's implicated in these other conditions. Next, thanks. And any mitral valve surgeons would tell you that increasingly we recognize a significant incidence of atrial functional mitral and tricuspid regurgitation. So this occurs in patients with long-standing persistent AF where the atrium is dilated and therefore the annulus of each valve dilates and they get regurgitation. Sometimes primarily mitral or primarily tricuspid, but it's not rare at all. Click, please. And this is the most striking data. This is a US study from a few years ago. It's either Medicare or VA, please forgive me, but it's a selected group of patients which may be relevant. But they looked at the incidence of morbidity and mortality after a first diagnosis of AF. And if you look at 5 years, there's a 50% mortality rate in this group. Of course, it's a particularly selective group, but that's, I think. Next, please. The potential benefits from surgical AF ablation, those of us conducting it are sold. Short term, we may relieve their symptoms of palpitations or shortness of breath. And certainly the patients who've been symptomatic with their AF very much appreciate losing it. There are potential long-term benefits with a reduction in the stroke risk, perhaps freedom from anticoagulation, preservation of the LV function, because that does decline with long-term AF, and also preventing mitral or tricuspid regurgitation. There is also the opportunity to exclude or excise the appendage, which we believe is important in reducing the stroke risk. I know someone else is going to speak about that a little later. There was a prospective randomized trial, LAUS-3 trial, not trouble, which is closed, but the data are not yet reported. Hopefully that will be very interesting. Next, please. So to my mind, this is the question really that we ask when I see a patient with atrial fibrillation. It's not should I perform, but is there any reason why I wouldn't perform an AF ablation? And if you're going to perform an ablation, why not do a full maze? I think the compromise procedures are limited. Next, thank you. And here is where we see how the COVID pandemic impacts upon the practice. The main thing is the altered case mix. The majority of concomitant AF ablation is in mitral valve surgery. That's how I came to be doing it. And during this period of very reduced capacity and activity, we've been focusing on symptomatic aortic stenosis, left main stem disease, and acute coronary syndromes. We are now treating some patients with mitral valve disease, and those with AF in my practice get an ablation at the time, but the case mix has been driven by capacity. So as I've already mentioned, I don't think there's any standalone AF ablation, and I think it would be very difficult to justify when everybody has gained 3 or 4 extra months of waiting. Still sticking to concomitant ablation wherever I have a case for it. And another issue is I do wonder that some surgical units might avoid AF ablation in this rather pressurized environment if they perceive there is an increased risk to the case. And I'll address that in subsequent slides. Next, please. So we have a little bit of data about surgical AF ablation, perceptions around it, and the results. This study here was a survey of those surgeons participating in the LAUS 3 trial that I've already mentioned. So these surgeons presumably are AF interested at the very least, but in patients having ischemic disease, the majority of patients received pulmonary vein isolation only, and only 20% received a full maze. And then even in the valve surgery patients, less than half received a full maze. Now, amongst this group, the factors which would lead them to be more likely to ablate would be young age of patient, smaller left atrium, and the presence of valve surgery, and we can understand all of those factors. However, it worked reasonably. So in ablated patients, the freedom from AF at 1 year was 53%. Now, what I think was very interesting from this study is when they looked at surgeons' viewpoints, the ones who did more ablation had a more positive perception of it. And that may relate to surgical familiarity with anatomy, I don't know. But the other aspect is that those surgeons who perceived a risk in ablation were less likely to conduct it. Next, thanks. So here's the big question. Does concomitant ablation increase the risk of your surgery procedure? And is it a mortality risk? Is there a perioperative stroke risk related, or does it just give you more heart block? Click, please. Now, we're fortunate. There's an expert consensus document addressing just these questions and looking at all the available data. Thank you. Click. And these are most of the questions this document addressed. So does a concomitant ablation procedure increase perioperative morbidity? And the evidence was not. Does it reduce the perioperative stroke risk? No, but it was not designed to. Does it reduce late stroke? That's a very important question, and I've put maybe here. I think the answer should be probably, but it's very difficult to get a good answer because of the way in which previous studies have been conducted and the numbers involved and the length of follow-up. However, does ablation improve AF symptoms and quality of life? Sure. Does it improve short-term survival? Yes. And does it improve long-term survival? Yes. Pretty compelling evidence. Next, please. And here's the long-term survival data from that. It's a meta-analysis, and if you look at the forest plot, you will see a significant survival benefit from AF ablation. Next, please. The majority of maze procedures will be performed concomitant with mitral valve surgery. And here's some of the evidence we have from such that. Click, please. So from Damiano's group, this is a very prominent AF ablating group. They looked at predicted versus actual mortality. And in the isolated mitral valve surgery, predicted and actual were the same. Thank you. When you add a maze, again, that does not increase the mortality compared with the predicted value. I think it's interesting, however, that the predicted risk in the maze group is lower than in the non-maze group selection, I think. Next, please. And then Nivad's group, which is the most preeminent in studying this. Click, please. They've looked at almost 500 patients having a mitral valve procedure with concomitant maze. And their perioperative mortality risk was low, stroke risk very low, and excellent rates of sinus rhythm with 80% at 5 years and 66% at 7 years. And their freedom from embolic stroke was very impressive. And that's even although most of these patients are no longer anticoagulated. And in this group of 500 patients, the stroke rate was 0.4 per 100 patient years. So 0.4% each year for each patient. Next, please, thanks. And same group, they looked at non-mitral surgery also, because this is perhaps less attractive for a maze procedure. And they had two groups having concomitant ablation, either with a mitral procedure or a non-mitral procedure, and they propensity matched these two groups. And these are decent sizes, 164 per group. The outcomes were similar. They had similar rates of freedom from stroke at 5 years, over 96%, and the proportion in sinus rhythm was also very similar. So I think you would suggest that it's worth conducting a maze not just in mitral procedures, but also in other cardiac surgeries. Next, please. So if you'll allow me, I'll share you some of our data to bring it a bit more real world. We're a middle-sized unit conducting 900 to 1,000 cases a year. And we've been doing surgical AF ablation for 16 years now, and we do about 50 cases a year. Perhaps very notable in the mitral valve cases, 20% of them get a maze. And we're currently conducting a full Cox maze 4 with a combination of bipolar radiofrequency and cryo, as discussed. And it's a biatrial lesion set, not just the picture I showed you. And these patients all get an appendage clip. Thank you. We looked at results over a 2-year period, and we were very pleased to see that at 12 months, 87% of patients were in documented sinus rhythm on Holter. And complication-wise, we had 1 stroke in the group of 100 patients, 1 TIA, 3 patients required a pacemaker, and 4 patients had a top-up ablation by catheter. And I think this is very important. Certainly our experience is a small number of patients get recurrent atrial fibrillation after a maze, or sometimes an unpleasant flutter. But usually this is due to a small gap in one of the lines, which a skillful EP colleague can deal with excellent results. Next, please. We've also looked at the question of high-risk patients, and for the purposes of the study I'm going to show you here, we chose patients who were over 70, who were in atrial fibrillation, who were having at least 2 other cardiac procedures, of which there were 300 patients, and you'll see that almost 200 did not have a procedure done, but we did 70 mazes in this group. Some patients had an appendage, and there was a small number of PVIs conducted. Next, please. And looking at the risk score, I think you'd have to agree these are high-risk patients with a mean log Euro score of at least 10. It's interesting that the PVI group have a higher risk profile than the maze group, so there may be some tendency for selection bias here. But importantly, all the bypass and clamp times are similar, and often the concern in adding an ablation is that you may add to the operative time. That does not seem to be the case. Next, please. So here are the results. Mortality, not altered. Yes, thank you. Permanent stroke postoperatively, very, very few. Thank you. Pacemaker requirements, 4%. That's very comparable to published results. And I think the last, renal support for patients who get an acute kidney injury, again, certainly no worse than complex procedure without a maze. Thank you. So in this same high-risk cohort, comparing the 4 modes of treatment or not for the AF, you'll see that at 1 year, the maze patients have an 80% rate of sinus rhythm, PVI maybe 55, and the others very little. Thank you. So I think we do have good achievement of sinus rhythm and no increased risk in this high-risk cohort. Next, please. So the question comes, when do you omit it? We've got some bullets here, please. So I think if they've had very long-standing persistent AF, it's well documented the results of ablation are worse. If the atria are markedly dilated, again, the results are less good. In redo surgery or in the presence of adhesions for some other reasons, I think a standard Cox maze becomes hazardous. I certainly would not pass a clamp behind the left atrium. It is still possible to do a cryo maze and conduct all the lesions with cryotherapy. It is more time consuming, but possible. Next, please. In some patients, there are genuine access difficulties. and it just isn't feasible if you cannot access the pulmonary veins. Thank you. There may be other issues with extreme surgical difficulty. I wouldn't propose this operation after a pericardiectomy, for instance. Thank you. And there'll be some patients in who there is an absolute need to minimize operative times for non-cardiac reasons, or in the case of difficult myocardial protection. And I think that should be borne in mind. Next, please. But in summary, I would say that surgical AF ablation still has relevance despite the current pandemic. I recognise that applications for this technology are reduced because the case mix is altered artificially by our capacity. But importantly, despite the perceptions that many may have, I have suggested there is some good evidence that AF ablation does not increase the surgical risk. Thank you very much.
Thank you so much, Mr. Billing. It was really nice talk,
Thank you.
Mr. Billing, and with the current evidences and also with your unit. It's really very impressive. Any questions, please?
Hello, hi, Mr. Billing, this is Ajay Subramanian here. I just had a quick question with regards to one of the indications you said not to do a maze would be where there is a significant atrial dilatation. I had come across this one procedure where there was overriding of muscle tissue of the LA between the two pulmonary veins, and then performing PV, a full maze after that. Does that have any substance?
I'm not sure. I have sometimes conducted ablation in people with a 5 or 5.5 centimeter left atrium. I think the evidence is quite good that the success rate of achieving sustainable sinus rhythm goes down once the atrium's over 5.
But is there any evidence to decrease the pulmonary vein dimension?
You mean a volume reduction procedure?
Yes, yes.
Yes, that could be considered. I don't know there's any evidence that overcomes the concern.
Okay, all right. Thank you.
So we've got some questions on the chat. Shall I just address those? There's a question about why patients with AF have a worse stroke. My understanding is that when it's an embolic stroke, you tend to block a larger vessel than if it's a local ischemic stroke. And then a question about LA dimensions. I think you'd like the left atrium to be less than 5 centimeter diameter if possible, simply because the success rate of your ablation is less. Although you may accept the different success rate and counsel the patient accordingly.
You asked, you said that you can't do it for pericardiectomy patients. It's difficult. Why it's a
with a pericardiectomy, if you get out of theatre, you're just happy. That's enough. I don't know about anybody else feels it's that. I think that would be gilding the lily.
So it looks like no more questions. Thank you so much, Mr. Billing. Thank you so much for coming.
Thank you for the invitation.
Thank you. So our next presenter is Professor Donna Eaton from Dublin. She is a cardiothoracic surgeon and also she is a cardiothoracic transplant surgeon as well. Donna, it's yours. Thank you.
Hi. Oh, sorry. Just organise my sharing of the.
That's fine.
First. Okay. Hopefully that's working. Thank you very much for inviting me. As Bhuvaneswari was saying, my name's Donna. I'm one of the thoracic surgeons in Dublin, and my main interest is thoracics and lung transplant. And I haven't really done any cardiac surgery such for certainly since I was appointed as a consultant. But I have a big interest in minimally invasive approaches for chest surgery. And that was really how I got involved with atrial fibrillation, specifically with left atrial appendage closure. So I thought I would go through in my talk really some of the evidence behind the left atrial appendage closure, and in particular the epicardial approach using the Atricure device, which is what I use, and then also just a little bit about our experience and the people we're treating, because they're probably quite a different subgroup to most units practice of atrial fibrillation. So the reason for occluding the left atrial appendage is that it's felt that by occluding the left atrial appendage, you will significantly reduce the incidence of stroke in patients. The epicardial approach, or the Atricure device, is very, if you're happy with the thoracoscopic surgery, it's very easy to apply using a thoracoscopic approach. It's very nicely designed for it. That's, and the other way of putting a left atrial appendage occlusion device is to put it endocardially, so a catheter-based approach. The advantage of the epicardial approach is that there's no risk of device migration. There can be with the catheter-based approach. It has a very good level of occlusion, being almost 100% at 97.8 or so, and it allows immediate cessation of anticoagulation, which certainly in the group of patients that I've been asked to look at has been quite important. So we thought we would look at the literature around left atrial appendage occlusion, specifically. So this is looking at a systematic review of the evidence for left atrial appendage and Atricure device. Next slide, please. Thanks. So in total, there's 922 patients. There's 11 studies included in this systematic review. Of those studies, the approach used was varied. If 4 studies used a thoracoscopic approach, 2 used mini thoracotomy, 4 was via sternotomy. And in those cases, like Stephen Billings just been talking about, there were generally patients who were undergoing cardiac surgery. And one study, there was no details of the approach used. So regarding the thoracoscopic approach, there was 410 patients in total. Long-term follow-up was only available for about 5% of those patients, only about 32 patients. Next slide, please. So looking at that group of 922 patients, 902 patients had complete left atrial appendage occlusion, and that's 97.8. So that's a very high number of patients who are getting complete occlusion of their left atrial appendage. For using an epicardial device, what's commonly used as the definition of complete occlusion is that there is no residual flow within the left atrial appendage, or that the residual stump is less than 1 centimetre. It's worth noting, though, that the commonest failure with that small amount where they haven't got complete occlusion, the commonest one is that the stump is more than 1 centimetre. There's actually no reports in the literature of an increased stroke rate with residual stump, and there probably isn't an increased stroke rate because you've got a very wide base of the stump with it. There's other surgical methods generally have a much higher narrow channel failure, so they have small gaps around the left atrial appendage where you still have flow, and percutaneous devices where, for instance, the Watchman device is being reported, they report complete occlusion rates in the 90s to high 90s. However, they include peri-device leaks of less than 3 to 5 millimeters, and there may be a risk of thromboembolic events with those peri-device leaks. Next slide, please. Looking at the stroke rate in those patients, the subsequent stroke rate was 0.3 per 100 patient years, and that's down from 1.4 to 2.2. So as Steve was saying, you get a significant reduction in the stroke. It's not completely eliminated because you have other sources of stroke, obviously. Regarding anticoagulation, the protocols varied in these studies, and often there was no consensus during the study of what they had, how they'd managed the anticoagulation, and it's often left to the referring physician, which I must say actually in my case is often what happens as well. There's no clear evidence, but it is felt that it's safe to stop anticoagulation as soon as the clip is applied. Unlike the endocardial, the catheter devices, there's nothing in the circulation, so there is unlikely that there's an increased risk of thrombogenicity when the clip's applied. So the position of it's confirmed by TOE, and then for many patients, the anticoagulation stopped there and then. Next slide, please. So 4 studies looked at device-related thrombus. So with other devices that are put into the left atrial appendage from within the circulation, there is a device-related thrombus, which is usually for about the first 4 to 6 weeks. For the Atricure device, there was 1 patient in the 252 patients that were looked at who had incomplete left atrial, and that's a patient who had incomplete left atrial exclusion, and they had thrombus within it. So that means that when the device has been applied, it has not completely covered the base of the left atrial appendage, and probably one of the little out pouches of the left atrium hasn't been covered by the device. But that's a much lower risk of thrombus than with other devices. There was no incidences of device-related complications in the group. There was no bleeding related to device placement, and the device was felt to be durable. Next slide, please. So in summary, the left atrial appendage was completely occluded in 97.8% of the patients. There was a significant reduction in their stroke. It's easy to place thoracoscopically, and it allowed immediate cessation of anticoagulation with no risk of device migration. Next slide, please. So the limitations of the study are the same as the limitations of many systematic reviews. They have a lot of reporting bias. There's heterogeneity of the studies. The studies have different designs, different methodology. The surgical approach was quite varied, and the procedure was as well. So some of those papers were looking at lone left atrial appendage occlusion, and others were looking at left atrial appendage in a setting of atrial fibrillation and cardiac surgery. Next slide, please. Thank you. Okay, so this is just to talk about the group of patients that I've treated. The numbers are probably slightly more than this now, actually, but it's just really to give you an idea of the group of patients that we've been asked to treat. So we've treated 23 patients thoracoscopically using the Atricure left atrial appendage device. In majority of those patients, so there's kind of, I guess, been 3 different groups of them. So the biggest group are patients where we're asked to do it as a standalone procedure, and that really is done purely for limiting their risk of stroke. So they're patients who are at high risk of stroke, perhaps aren't dealing well with anticoagulation, and we're asked to do a left atrial appendage device closure. The other group, which I think are probably increasing in my practice, are patients who are referred to me for a left-sided thoracoscopic procedure of another nature. And then on workup, I realised they've got atrial fibrillation. And now my practice is that in those patients, I'll put a left atrial appendage device on at the same time as they're having surgery. And then the third group, or the group that actually were the group that I started doing this procedure for, which are patients who either we've been asked to do a full thoracoscopic atrial fibrillation ablation, and we're putting on a left atrial appendage clip obviously at the same time as that, or patients where they're having their full ablation done as a hybrid procedure. So they'll have their catheter-based vein ablation, and then under the same anaesthetic, they'll come into theatre and have their left atrial appendage applied. So those patients now are totaling 5 and are probably the slowest growing group with it. So most of them now are either standalone or they're having it as part of their left-sided thoracoscopic procedure. Next slide, please. So for the group that are thoracoscopic clipping only, 3 of those patients were referred because they'd had a bleed previous, a cerebral bleed previously, them for previous GI bleed, 2 of them for risk of falls, and 2 of them had had prior catheter ablation and had recurrent atrial fibrillation, and it was felt that they should have their left atrial appendage occluded to reduce their risk of stroke, but also as potentially that could be the source of their ongoing atrial fibrillation. Next slide, please. So for the patients that are thoracic patients having other thoracic procedures, There's been 8 of those. 7 of them had asymptomatic atrial fibrillation, were all aware that they had atrial fibrillation, but hadn't had any complications as such. And 1 was symptomatic, as in she'd been treated for atrial fibrillation, and she'd had a hemarthrosis. She was kept on anticoagulation. She'd a further hemarthrosis of her knee and ended up with a knee replacement as a result of her anticoagulation. So when she came to see me for an entirely different reason, and I suggested we could do a left atrial appendage clip at the same time and get her off anticoagulation, then that was obviously a very appealing option for her. In fact, of the indications for their thoracic surgery, 3 of them have been having lung resection, generally for lung cancer. 3 were thymectomy patients, and 2 of them were patients who were referred for lung biopsy for diagnosis. Next slide, please. So this is just to show you the incisions that we use. So we have 3 ports. We have 1 small anterior port, which is in the second intercostal space in the midclavicular line, and that's a small 5mm port. The camera port is put in laterally, just at the anterior axillary line, and that's a 10mm port. We used to have, and this marking on this patient is probably from that, used to have a slightly bigger incision because the Atricure clip was on a slightly bigger housing, but now the incision for the clip siting is done just at the base of the mammary crease, and is again another 10mm port. Next slide, please. Thank you. So this is, I thought there'd be lots of pictures of this already, but actually this is just to show you a picture of the Atricure left atrial appendage occlusion device. So it's put in under direct vision. So you have the camera inside the chest. There have the lungs isolated using a double lumen tube. The lungs completely isolated. You open the pericardium just behind the phrenic nerve, anterior to the phrenic nerve. The left atrial appendage kind of pops up at you as soon as you've done that. You make sure it's freed from the surroundings and that you've located the base of it, and that you're happy that you've identified the full extent of the base. And then you pop this clip initially over the top of the furthest away point of the left atrial appendage, and then maneuver it down to the base and then withdraw it. The picture I've got here is a slightly older clip, which has the metal at the front of it. The casing covers the front of the clip as well as the other 3 sides of it. The new one, which I couldn't find a picture of, is missing this little front piece of metal, which makes it even simpler to remove, because you just pull it straight out rather than having to pull it back off from the left atrial appendage. Could I have the next slide, please? So for our group of patients, in terms of complications, all the patients undergo an on-table TOE before we start the procedure. And that's really to make sure that there's no clot within the left atrium before we start manipulating it. And in 1 patient, there was clot in the left atrium, so the procedure was delayed. So we just cancel the procedure, we reevaluate their anticoagulation treatment, and then proceed at a later date. So in that lady, we just carried on 6 weeks later, did another TOE, and there was no clot the second time, and then we carried on with the procedure. Post-operative complications, I've had 2 patients who've had a kind of irritation of their pleura or their kind of serositis, where they've had fluid in their pleural space as well as around their in their pericardial space. It causes an effect that's quite like pericarditis, and my feeling is that it is an irritation of the pericardium, and that it's probably secondary to the clip moving against the pericardium. So I now push the pericardium out of the way so that it's not in contact with the clip. However, I did talk to somebody who does the exact opposite and feels that that's why they don't have those complications anymore. So I think it may well be just one of these things that the more you do, the less you see it, because it was certainly at the beginning of my experience. In terms of the length of stay, if they're having it done for lone left atrial appendage clipping, their average length of stay is 2 days. Next slide, please. So I started to find the Atricure device to be very straightforward. It achieved complete occlusion in all cases. We check it with a TOE after the procedure. The deployment is very straightforward. It takes 30 to 40 minutes to do the whole procedure. It's very safe, it's very reliable, and it's very well tolerated by patients, to the extent that I'm very happy to add that on during a long lobectomy case, for instance, to put a left atrial appendage clip on at the end of the procedure if that's required. Next slide, please. So the left atrial appendage device, I think, is absolutely ideal for patients who fail anticoagulation. So as you know, there's a lot of reasons why your patient might not tolerate anticoagulation, and some of those are just the fact that they just might not take it. But also there's a lot of patients who they are unable to tolerate because of GI complications or other bleeding complications. It's been recommended by the ESC guidelines that left atrial appendage occlusion should be considered in any patient who has a contraindication to anticoagulation or has a very high risk of stroke. I think there's a very big group of people where compliance is an issue. We know that from looking at warfarin, but with the newer oral anticoagulation, because they actually wear off quite quickly, their complications related to non-compliance may well be a lot higher than we're expecting. But also, certainly patients who get a thromboembolic event despite being on anticoagulation should be considered for a left atrial appendage clip. And as I've said, currently all my patients who are undergoing a thoracoscopic procedure on their left side with a history of AF get a left atrial appendage clip. Next slide, please. Thank you. So apologies again for the slides being a bit messed around there, and happy to take any questions. Thank you.
Thank you so much, Donna. I think we have some questions coming.
Well, I can see one of them, which is asking why we wouldn't offer these patients a full maze. So quite a few people have probably heard this discussion before. So these are patients that are referred from, generally coming from the cardiology team. So they've usually had an ablation procedure previously, and they're referred specifically for a left atrial ablation. So if it's a patient who hasn't had a number of catheter ablations in the past, then I may well have a conversation with cardiology about doing that. But actually, I really never see those patients. So I don't get referred patients who haven't already had a number of catheter ablation procedures. And I've done a maze procedure in a couple of those patients previously. And if they've had quite a lot of catheter-based procedures in the past, they're very difficult to do. So I think if you had a patient who's got atrial fibrillation and is able to withstand a 2-hour to 3-hour operation, then a full maze is very reasonable. But they're just not the type of patients I get referred. I generally get them referred after they've had a number of catheter ablations in the past.
Do we have any more questions, please?
Miss Eaton, there was a couple of questions actually I had on my mind. The first one was when you mentioned that post-atria clip, most of these patients, obviously they're getting referred because they've got some kind of contraindication to anticoagulation. My question was, is there any particular LA size that you keep as a borderline where you stop anticoagulation post-clipping? What I mean is sometimes we see thrombus forming on the back wall or on top of the roof, like just kind of hugging the wall when the atrial size is very significantly dilated. So is this something that you rule out post-operatively on the TOE before you stop anticoagulation? And the second question, if I may ask, is sometimes there is a bit of device migration, and you've mentioned that if the LA stump is more than 1 centimeter, then there is a probable risk of a future TIA or stroke. So these patients, once their anticoagulation has been stopped, in the future, do they ever have like a repeat TOE to just confirm the device position?
So my patients have a TOE with it at the time. there hasn't been, to my knowledge, with the Atricure clip, there hasn't been any device migration with it, and it pretty much it bites into the tissue and fibroses across it and scars it. So I can't really imagine that you would get a bigger stump on it than you had to start with at it.
The LA size, what are your thoughts on that?
In terms of stopping their anticoagulation, many of my patients aren't on anticoagulation because they've had complications with it before and are coming without any anticoagulation. So then I have no problem with it. So I don't have to make a decision one way or another. If they're straightforward and there's no concern about the size of their left atrial appendage, they stop it. And if it's larger, then I send it back to the cardiologist and allow them to decide when they want to stop.
Okay, thank you very much.
Thank you so much, Donna. Thank you so much. Nisha, would you like to introduce our next speaker, please?
Yes.
Sorry, there is one question there for Donna. What type of follow-up do you offer patients, or they back to cardiology or GP, Donna?
So they come back to me for because they're having thoracic surgery with it and they've got VATS ports, they come back to me for their pain management post-operatively. They come back for usually at least one post-operative review, but usually 2 post-operative reviews up to 3 months. But then their follow-up, if it was for lone left atrial appendage clipping, goes back to their referring cardiologist or their GP.
So Donna, there is another question for you. If you want to, do you think that there would be a role of AF ablation for a general thoracic surgeon?
Yes, I do. I think I had a proctor over for me doing the AF ablation, but to be honest, it's if you're used to doing thoracoscopic procedures, it's not out with surgeon to start to do AF ablation. I think it's just you're probably not involved in the pathway of referrals as easily as a cardiac surgeon would be. But I think it is a very transferable skill for a thoracic surgeon.
Thank you so much.
Okay, thank you.
Our next speaker is Mr. Syed Ashan, consultant cardiologist and electrophysiologist at Bart's Heart Centre, London. Mr. Ashan is also a cardiology lead for surgical ablation. Mr. Ashan set up first UK hybrid AF program at the Heart Hospital in 2012. And Mr. Ashan has got an active interest in surgical AF ablation. Today, Mr. Ashan is going to give us a talk on perspectives of a cardiologist on atrial fibrillation. Mr. Syed Ashan, all yours. Sorry if I missed anything.
No, thank you. I'm a cardiologist, not a cardiac surgeon. Thank you to Bhuvaneswari for organising this and inviting me. So my talk today is going to be divided into sort of 2 sections. The first section is I just wanted to talk to you about some of the statistics regarding AF, and I know Chris, following on from me, will go into a bit more detail regarding that, but it's really just to emphasise why has AF now become an important thing, and why should we stop it from being overlooked in terms of surgical treatment. And the second half of the talk will be regarding the more regarding the convergent AF ablation, which I've been involved in for some time, and just giving you a slight update on the data. So this is a slide which is showing the prevalence of AF in the United States. It's going to be an increasingly common condition, with the prevalence increasing rapidly with age. And by 2050, there's going to be a huge rise in AF. The lifetime risk in the States is quoted as 1 in 4 for men and women over 40 years. And in the UK and Europe, at some point in our lives, 1 in 3 of us will be diagnosed with AF. So it's a hugely common, very important condition. Just over 1 million patients in the UK have been diagnosed with AF, and a lot of patients remain undiagnosed. And again, the number in Europe of patients with AF is expected to double in the next 50 years. Atrial fibrillation increases the risk of virtually all these cardiac conditions. So everything on the right of the graph shows an increased frequency. So it's not a benign condition. And Steve Billing at the beginning of the session mentioned that, years ago we would just put patients onto medications and anticoagulate them. But we know that, the stroke incidence is significantly increased, and the severity of those strokes, as has been mentioned earlier, is significantly worse. From an NHS cost perspective, AF places a huge burden on the NHS, and is likely to continue to do so, and increasingly so. So in 2000, the cost of AF to the NHS was about 459 million, so 1% of total NHS expenditure. This is likely to have increased by about 20% since then. And in 2015, we were expecting just under 203,000 first ever diagnosed AF cases. So this increases the number of hospitalizations, the number of strokes, the cost of medications. So it's an important condition that we need to be fully aware of and treating to the best of our ability. This slide, I just wanted to show you this slide because one of the criticisms that we as a community get for treating AF is, well, we can manage these medically, and actually ablation, either catheter-based in the cath lab or surgical ablation, has no real role. And if we look at the data, what's important to explain to patients is that antiarrhythmic drugs, one of my colleagues did a meta-analysis on this, which is in press now, carry a significantly increased mortality. And it's quite dramatic if you look at it. If you look at the numbers there in red, sotalol, quinidine, amiodarone are all drugs which increase mortality. So these are not benign medications that we're putting patients on. They carry an increased risk. And it's important for us to be aware of that, and important for our patients to be aware of that. What else? Well, the most recent catheter ablation trial for AF, called Castle AF, which looked at patients who had heart failure who underwent ablation, and compared these to the same population with AF and heart failure who underwent medical treatment, showed a significant benefit of all-cause mortality. What I wanted to illustrate in this slide is what we've got here along the bottom. These are some of the landmark cardiology studies, including medication studies, cardiac resynchronization studies. And what we've got on the y-axis is the number of patients needed to treat. And you can see that all these studies, the catheter ablation for AF in patients with heart failure, we need to treat the fewest patients to have a significant mortality impact. So, ablation for AF is important, and has got proven data now. What about surgical AF ablation and concomitant surgical AF ablation? So this study looked at 79,000 Medicare beneficiaries in the States, and 28% of these had atrial fibrillation. And as we would expect, patients undergoing mitral valve replacement or repair have the highest incidence of concomitant AF. But only 22% of these patients had surgical ablation. Those undergoing mitral valve surgery, only 38%, and non-mitral valve surgery, 16%. Now, if we look at the most recent surgical guidelines for ablation of concomitant AF, this is now a class 1A indication. Yet in the UK and the States, we're still not, treating these patients appropriately. And given the data that we've just seen, it's imperative that we do so. So I just wanted to move on a little bit to talk about convergent AF ablation, which is something that I have a particular interest in. And just taking a step back, the AF, persistent AF, there's a critical mass of atrial tissue which is necessary for the atrial fibrillation circuits to propagate and to maintain. And this is dependent on the muscle mass. So in a mouse, we never see AF. In humans, we see AF occasionally. In horses with larger heart muscle, we see AF more frequently, and whales are always in AF. So the mass of tissue is really important. I'm just going to play a quick video and talk you through the importance of the mechanisms in atrial fibrillation. So this is with regards to persistent atrial fibrillation. As you all know, you've got pericardial reflections, which maintain the heart at the top. And over time, particularly with risk factors, and as you develop AF, if you have concomitant risk factors such as diabetes, hypertension, obesity, sleep apnea, all these things, the posterior wall of the heart stretches and it's held in place by these pericardial reflections. And as the heart stretches, over time, we begin to develop areas of scar tissue or fibrosis. Now, these are very hard areas to visualize on cardiac MRI scans or other types of imaging, but we know it's there. And these areas of scar tissue or fibrosis are patchy. The patchy scar leads to circuits running around them, which enables us to propagate AF. And this is the whole premise of the convergent approach, which is to debulk this critical mass of fibrosed tissue on the posterior wall. We've already heard about the gold standard Cox-Maze, which carries extremely high success rates. And we know that catheter ablation, as electrophysiologists like myself, it's great for isolating the pulmonary veins. So patients with paroxysmal AF do extremely well. But in persistent AF, we're not having the same success rates. And this is because we just can't address, firstly, we don't know what all the mechanisms for maintenance of persistent AF, and there's been lots of theories, but with a single catheter we can't treat this effectively. So what the convergent approach does is allows us as electrophysiologists to work together with cardiac surgeons to form a truly functioning heart team. And this multidisciplinary approach, where the surgical part of the procedure is debulking the posterior wall of the left atrium epicardially, and then the patient returns for a stage procedure with an endocardial catheter-only ablation, leverages the best of both worlds. It's a minimally invasive procedure, minimally invasive surgical procedure, which is taking between 90 minutes to 2 hours. And the epicardial ablation is performed under direct endoscopic visualization. And again, on this animation, we see a subxiphoid approach, which is the most common approach used now. We were using a transdiaphragmatic approach, but most centers have now switched to a subxiphoid approach. You have an irrigated unipolar ablation catheter, which is introduced to the pericardium, and energy is delivered away from the esophagus to minimize the risk of esophageal lesions. And the advantage of this compared to a catheter ablation that we can perform is, the length of these lesions. If you think of an endocardial catheter, it's a point-by-point lesion set, where these are long overlapping lesions. So we can effectively debulk the posterior wall. This can be done as a joint procedure with the catheter ablation, but in the UK, mainly we're doing it as a staged procedure now. And the surgical component does not require thoracic skills. It does not require VATS or deflation of the lung. The patient has a relatively short hospital stay, and it's a relatively quick and easy procedure to learn. So we looked at our data at Barts and the Heart Hospital beforehand, and we basically randomized patients retrospectively to two groups: those patients in green who underwent the convergent procedure, and those in blue who went a catheter ablation. Now remember, these success rates don't look good, particularly good, 58%. You could argue, well, this is not great. But remember, these were long-standing persistent AF ablation patients, so patients with dilated left atria, often above 5 centimeters, often with concomitant conditions such as cardiomyopathies, who had been in AF for a long time, with a mean duration of AF of over 3 years. So really, this is the patients group that does worst. Our data has been supported very recently by the Converge ID trial, which was a multi-center randomized control trial. This randomized 153 patients to 2 arms in a 2-to-1 ratio. So half the patients, 102 patients were treated with the conversion procedure that you've just seen, and the remainder were treated with endocardial catheter ablation. And they were followed up for a year with Holter monitoring and telephone calls and echoes, so quite follow-up. And again, what the data shows is a significant advantage of the convergent approach versus endocardial catheter ablation, as you can see on the graph here. So the first randomized controlled trial demonstrating a head-to-head comparison with catheter-only ablation. So the conversion approach is a true multidisciplinary approach where cardiologists in combinations with cardiac surgeons are delivering better results for patients with long-standing and persistent AF. So the conclusions from my talk today is that AF is not just something that is there and we can ignore. It's a growing epidemic. It clearly leads to increased mortality. Drugs used for the condition are not without complications. AF-related costs are placing a huge burden and will continue to place a huge burden on the NHS. We've demonstrated that AF ablation is associated with significant clinical benefit, and concomitant ablation at the time of AF, at the time of cardiac surgery, is not only cost-effective, but works and is underutilized. Convergent ablation, as we've just seen, offers a treatment proven in a recent randomized controlled trial and is the first way we can use a true multidisciplinary heart team. Thank you. Any questions? Do I think AF is undertreated? Yes, absolutely. I think, you know, over the last 10 years, we've highlighted that AF is undetected AF is one of the key things. There's been many talks about screening asymptomatic patients for AF to reduce their risk of stroke, because one of the fears is that the first presentation for AF is often a severe stroke. So I think we will move towards screening over 65-year-old for AF, and I think it's definitely undertreated, particularly as we've seen with the data at the time of surgery. I mean, someone having a mitral valve replacement or mitral valve repair, if they're presenting with AF and we're not treating it at the same sitting, I think that is just terrible. This is a class 1A indication, so the data and the evidence from all the society guidelines is strongly in support of this. My feeling is that this is always the poor relative to the meat of the case, which is the mitral valve replacement. And I think we need to try and change that mindset, because I'm sure the mitral valve will be doing very well with the skills of my surgical colleagues, but the AF may be the one that limits the patient symptomatically or kills them because of a significant stroke. Yeah, how many lesion sets are required, or is it just interpulmonary area that governs it? So for paroxysmal atrial fibrillation, we just need to isolate the veins, and the pulmonary veins, pulmonary vein isolation for paroxysmal AF carries a very good success rate, with the latest data approaching between 85 and 90%. So that's fine. We can do that in the cath lab. Persistent AF ablation, the data is, from a catheter-only ablation is much worse. The lesion sets that are typically done, or certainly which were done in the Converge trial that I've just shown you, was ablation of the posterior wall, and then the patient would come back to the catheter lab and have a CTI flutter line. Now, everyone in the community with a convergent AF ablation are doing slightly different things in terms of the lesion sets. So as a group of cardiologists and cardiac surgeons performing the procedure, it's one of the things that we need to agree on. But the mainstay of this procedure is trying to isolate the posterior wall and making sure the pulmonary veins are isolated. How long following AF surgery, for how long do you keep patients on antiarrhythmic medications? So that's a good question, and it really depends. I mean, our practice is to continue anticoagulation indefinitely if they've got a high Chad's score. If the patient maintains sinus rhythm, we would look to take them off rate control medications quickly, so drugs like bisoprolol and digoxin, and try to take them off rhythm control medications between 3 and 6 months. If at 1 year they've not had a recurrence of AF, the chances of remaining in sinus rhythm are very good. What should be the best treatment for those patients post-cardiac surgery with persistent post-op AF? And what should be the best standard follow-up after surgical care? So there are clear guidelines on management of AF post-cardiac surgery. In the short term, using a drug such as amiodarone and anticoagulating the patient is reasonable. Most of these patients would have had some of these patients would have had AF preoperatively, and that's why we should actively be looking for it preoperatively. But obviously, post-op AF occurs commonly. Most of the cases can be managed medically, and they should be followed up in an EP clinic with further Holter monitoring to evaluate the AF and whether it needs further treatment. What are the incidence of patients requiring surgical AF ablation after catheter ablation? So that's a really good question. From our experience, when we first started the hybrid program, we got a lot of patients who had multiple failed catheter ablations. So those were the patients who have long-standing persistent AF, have significantly dilated left atria, who have comorbidities. So these patients were never going to do well after a catheter ablation. So it's the group of patients that we wouldn't like to ablate as electrophysiologists who've historically had surgical AF ablation. I think with the results of the most recent trial, our threshold for doing a hybrid procedure has changed. So we would now incorporate all patients with persistent AF who would potentially be considered a candidate for a surgical AF ablation. I'm aware of time, Bhuvan, and talked a lot. Bad predictors of recurrence following AF surgery. So I think all the things that I've mentioned really, the comorbidities, hypertension, diabetes, kidney failure, duration of AF, a dilated left atrium, and poor left ventricular function. But what is really interesting is, and one of the things that we're looking at going forward, is we're trying to look at the, it's been evaluated on MRI, it's called the Utah fibrosis score. So if we can try and quantify the amount of fibrosis or scar tissue in the left atrium, that's probably going to be the single most important predictor for the success of any type of AF ablation, be it catheter or surgical. And I think that will be the real important thing to decide. Depending on how much fibrosis the patient has, their success rates will be inversely proportional to that. Good. Thank you again, Bhuvan, for inviting me. It's been a pleasure to speak, and I hope to see you all soon.
Thank you so much. Nisha?
Yeah, our last but not the least speaker of the session is Mr. Chris Theaker, Product Marketing Manager, Atricure, on perspectives of an Atricure manager.
Thank you very much. Thank you very much, Bhuvan, and your team. So this is really not looking at it so much as from a product specialist point of view. I thought I'd change things a little bit, and rather than my view, I thought, look, what is the patient's view of AF, and what the suffering and what's the burdens that patients with AF have to endure? So we look through the literature, and I think some of this may be a bit surprising. So we've heard today excellent talks on the fact that we know that patients with AF have an increased risk of stroke, up to 5 times or a 500% risk of stroke. But they also have an equal risk of developing heart failure as well. And what I'm going to do is go through each of these points in turn. There also has been, as has been alluded to earlier, 46% greater risk of death. Now, a lot of people, when I presented this data, they don't believe that. They struggle with that idea that AF is just a benign condition, as has been mentioned earlier. And really, it's the valve that we all need to worry about, or the a graft that needs doing as well. But what we have in mind is actually, yes, the patient may have a valve issue or a graft issue that needs treating, but they've got AF, so they've got 2 completely separate clinical entities, both within their inherent mortality and morbidity effects on them as well. And if you're just treating the valve or just doing the graft, you have not negated at all the risks associated with AF. Those inherent risks still occur. There's also a lot more cardiac complications. So let's go through the slide now and see what I mean by the 5 times increased risk of stroke, the heart failure, and the greater risk of death. So we know in Europe, from the data we've looked at, that about 15 to 20% of all strokes are caused by AF. And as has been alluded to earlier, those strokes are usually very devastating as well. The left atrial appendage, blood washes out from there and goes straight up and causes a pretty severe stroke. It's often fatal as well. Now, the problem is a lot of people can think, well, it's okay. The patient, although they're in AF, they're on their warfarin already. Well, the problem with that warfarin at the minute is even if you are on warfarin, you still have a 2 to 5% risk per year of getting a stroke as well. So although it is been seen as a very high standard, a very good therapy, it still has its own inherent risks associated with it, which begs the questions, do we now need, or do we also need to look at other measures other than anticoagulation to really reduce that risk of stroke significantly? We also know that there's a significant risk of patients discontinuing their anticoagulation therapy. In fact, the data is highlighted here shows that actually up to 50% of patients stop taking their anticoagulation within the first year of commencing it. This is largely due to the fact they don't feel any clinical benefit from it. They can't see why they're taking it. They don't like it. They know it's rat poison. And also the other thing as well is they have intolerance to it as well, as was referred to earlier. So that's the risk of stroke. It's something that needs to be addressed significantly when thinking about a patient with AF. As they get older, of course, that risk of stroke increases as well. But also it's a significant risk, and we'll look at the data of this in a minute, about developing heart failure. The phrase used to be AF begets AF, but actually AF begets HF, and HF begets AF. You'll find that a lot of patients who have been in AF for some protracted period of time will go on to develop heart failure. But the reciprocal is true further as well. You have patients who have heart failure will likely or have a high chance of going into developing AF as well. But by treating the AF, you can restore sinus rhythm, which can improve significantly the ejection fraction, which can help bring down those breathless symptoms that patients have as well. There's also data to show that if you're treating, as was referred to earlier in the trial that Dr. Syed mentioned to Dr. Syed Ashan referred to as well, that there's a reduction in mortality in these patients with AF and heart failure if you treat the AF as well. Finally, it's strange to think this survival associated with AF. If we look at the survival of cancer overall, if you've got all the cancer patients, and we looked at the survival rate of all the cancer patients, we see that on average of all the cancers, about 51% of patients survive their cancer. However, with AF, if you were told that you had AF, you wouldn't put that, you wouldn't think that it was a disease that had that sort of mortality rate associated with cancer or benefit associated with it as well. And overall, the rate of you surviving cancer is 58%, but your rate of surviving AF is 51%. So you've got a less risk, less chance of surviving your AF than if all the cancers that have been put together. So maybe I didn't explain that very well. So maybe the next chart will show that in greater detail, and we go into that as well. So if we look here, I think some of you may have already seen this graph, but if we look pancreatic cancer, your 5-year survival rate is 4.1%, so very poor, but your prostate rate of surviving over 5 years is 99%. But if you look here, we see that atrial fibrillation, 5-year data, only 51% survival rate. So if you were diagnosed with chronic leukemia, you actually have a better chance of surviving that over 5 years than you do your atrial fibrillation. Now, I think a lot of people have already been curious about that. So let's look at the data. And I just want to pull up 2 papers now that I'll start to share with you that reinforce this message. So they've already been referred to earlier. This paper here. You should see a paper by Piccini and colleagues. This paper here was referred to earlier by Mr. Billing, and he pointed out that this is an American study looking at Medicare patients. And you may think, well, what's the relevance of that? But first of all, before we take that into context, let's look at the data. So if we scroll down, we see here the primary cohort, no recent events. So these are patients who had no recent events before their AF. So they didn't have a heart attack, they didn't have a recent stroke, or didn't have any heart failure. And we see that from the point of diagnosis, the greatest risk was death. In fact, if you look at year 1 year after diagnosis, 1 year, 20% mortality rate. But if you look at the stroke risk was nowhere near that high as well. But we see that start to rise exponentially over the course of time, leading to around 40%, 40 to 50% mortality rate at 5 years, all-cause mortality rate. And these are patients who've had no recent events. That arc, that gets more and more steep if the patient had a recent event. So if a patient had recent heart failure and then developed AF, their risk of death goes up exponentially as well on a greater steep. So at 1 year, so if you have recent heart failure development, you develop AF, 1 year, you've got about a 30 to 35% mortality rate. At 5 years, if you've developed recent heart failure, you're up to about 60 to 70%. Now, as referred to earlier, these are American patients under Medicare, and you may think, well, that doesn't have a great deal of wash with us here in Europe. But another paper here, you should now see a paper by Odeteo that was published in the British Medical Journal. And this finding is a systematic review of all instances of atrial fibrillation and the associated comorbidities associated with it. And this graph has already been shown, but just to hone in on the detail here, if we look again, all-cause mortality, we see 1.46, the relative risk is 1.46, anything over 1 has an association with mortality, so we see there is a 46% mortality associated with the development of AF, confirmed in global studies in a systematic approach as well. We see it's not just from one particular study, we see it's from 66 studies confirm this data as well. Now, if we briefly drop down to heart failure, we can see again 4.99. So that's where we get the 5 times risk of developing heart failure. But if you look at the spread of that data, we see that some patients can be as low as a 3 times risk of developing heart failure associated with AF, still a significant problem. But some are over 800% more likely to develop heart failure associated with AF. So they're pretty powerful statistics confirmed not just in one study, but in 2 studies, and one of them was a systematic review of all clinical papers on looking beyond the effects of stroke associated with the development of AF. So I'll quickly switch back now to the other slides. I'm aware of time is creeping up on us, so I'll be as quick as I can. So that's the mortality issue with it as well. But there's also additional suffering with these patients. They get a significant reduction. Their quality of life has been shown to reduce by half. So can you imagine that one day you've developed AF and then within a few weeks, your quality of life, your suffering has gone up by 50%, or your quality of life is reduced by half as well. Many people have to take multiple hospital visits associated with their AF as well. There's plenty of data to show there's mental and physical decline associated with the acquisition of AF. But more often than not, as was mentioned earlier, a lot of the drugs don't seem to have any therapeutic events. So there is evidence to show that up to 50% of patients who are taking oral antiarrhythmics has no clinical benefit on it whatsoever. Well, so this comes to the point really, and I think this has been addressed a little bit before, in that we really need to start screening patients associated with it, particularly patients who are coming for surgery, coming for cardiothoracic surgery, and could have a concomitant ablation at the same time if they're a valve or if they're a graft patient as well. And actually you think, well, screening, maybe that's quite a headache. Maybe I've got quite a lot to do there. Well, actually, you can just ask them some very simple questions. Have you ever been told you had an irregular heartbeat Do you have heart palpitations? Have you ever taken blood thinners before? Or do you take any medications to manage your heart rate? Then all you can do is just have a quick shift through the patient's notes as well and to see if they've had a history of past AF diagnosis, if there's Holter monitoring or history of a cardioversion, or also there's a history of ablation. So it's a very simple process you can put in place to identify these patients, because as was mentioned earlier by Dr. Ashan, that a lot of AF isn't treated because these patients aren't always picked up. Sometimes the clinical problem seems to be associated with the valve, but everybody thinks it's the valve or it's the graft that's causing the symptoms in these patients, but it could equally be episodes of AF coming in as well that just haven't been correctly captured or managed as well. And finally, there is data to show, this should say the importance of an AF coordinator in patients who are managed by, it does say nurse coordinator, but that's an American thing, but it should be any coordinator. There's plenty of evidence to show that if you have a nurse or any other allied healthcare professional who can identify and lead these patients through the surgical procedure with AF, they do better. Particularly, there's a reduction in length of stay on ICU. And at the moment, as we know, there's been a horrendous amount of pressure on the ICU beds. And this is one way that could potentially help reduce that pressure on it. There's fewer readmissions as well, and improved outcomes in these patients as well. Now, if you go in the cardiology route and you have AF, you will find you'll have an arrhythmia nurse who will help guide you through the care, identify you, and do a lot of work. However, if you have a surgical valve problem or a graft that needs correcting and you have AF, at the moment, there's no pathway associated with these patients. So maybe the solution is somehow to try and find somebody who can ask some relatively straightforward questions, but also guide the patient through this process and also make sure that that risk of mortality, that risk of stroke, that risk of heart failure is reduced significantly and that their symptoms improve over time as well. We've seen plenty of data to show that AF is not a benign condition. And I think we have to be careful not to trap ourselves in the past of thinking that AF is just an also-ran. As I said earlier, AF is a condition with its own intrinsic, inherent mortality and morbidity risk associated with it. And I think to conclude my talk, the only thing I would ask is just to keep your eye out for AF, because it's been shown it's going to get worse. If we look at the data here, we see in the USA, which is the number one most ablating country in the world, I should imagine that figure's probably gone down a bit now due to the coronavirus issues there. Only a third of patients are ablated who could have been ablated. We know that there's a significant increase in Europe. We will be seeing the incidence of AF going up over time. Up to 14 to 17 million people in Europe will have it, putting a significant burden on healthcare as well. So not only is it a problem for the patient has to endure a lot, and there's a significant risk of problems, heart failure, stroke, and death. The problem itself is also increasing. Now, we've had a look at some data, and we think that at the moment, of all the patients that could have been ablated surgically when they came in for surgery, cardiothoracic surgery, we think in the UK only about 15 to 16% of patients are actively ablated during this time. Now, obviously, there are some centres who are fantastic and they ablate patients and see great outcomes associated with the treatment, doing surgical treatment, but other centres are not so good, unfortunately. And I think that the real challenge now, as has been echoed by all those who've spoken today, is to really start to pick up and treat AF and give it the proper attention it needs to be given. So on that note, I shall hand back and answer any questions unless people want to get off the call and start to enjoy their Saturday evening. But thank you so much to all of you for listening, and thank you so much for Donna for organising this.
Thank you so much, Chris. So what do you think about point of company perspective? The incidence of AF is increasing, as you said, but do you have any planned 5-year strategy or anything to put it in plan to reduce it? Or are you talking with the NHS England?
Yes, we are actually. We are having good discussions with a very helpful support from Dr. Ashan as well. Is very much supporting us in that, and we're trying to work together to produce documents to show the NHS. Not only that it is undertreated, that this condition is lethal, and that it's on increase as well. So that much work is very much going forward. It's put on hold a little bit because, of course, of the pandemic now as well. We really have been pushing. We're trying to organise a working party to get some documents together to present to the NHS as well. I think this is a problem which is going to be increasingly more because there's so much attention given to the cardiology side of it, and it's also neglected on the surgical side, but it has profound implications. So as a company, we're trying to work with key opinion leaders to sort of drive the message home that this is an inherently serious disease associated, with patients with valve problems and heart problems, but also, as mentioned before, with the convergent data as well, where you have patients who are treated surgically for AF and they don't have any valve or graft problems or of that issue as well. So I think that's going to come more and more over the next few years and sort of really show that it's not so much about just cardiologists, it's about a whole heart team approach involving everybody in that. That's a big thing for the societies. They're all saying now we should really be looking at a whole heart team approach. And just as patients are discussed about their valve, what valve and who should be done, AF should be discussed in the same context as well.
Thank you. So another thing, very interesting thing you highlighted, that they have an arrhythmia nurse, they have an AF coordinator, everything, but surgically we do not have anything. Like I do as a researcher, I follow up most of my patients, they're all on AF drugs. And recently I am comparing 49,000 patients who had coronary artery bypass surgery and 50% on AF drugs, and no one follows that up. Only GP is the one, or the cardiologist has been sent back to, because surgically we don't see them because of one is money factor, second manpower. What do you think about that?
I think that's a very, very important point there. And I think that not only does that, that an issue in itself, but we heard earlier from Dr. Ashan about the mortality rate that are associated with antiarrhythmic drugs as well. These are quite lethal drugs. I mean, you saw some of them there, 100, 200% risk of sudden death associated with the taking of these drugs. And the fact that nobody is following them up and just leaving them on this drug is an inherent problem in themselves. This is why if you can get a good ablation done, we did see data that's showing that you can reduce the amount of use of antiarrhythmic drugs as well in these patients, rather than just leaving them on. And I think that heart team approach, somebody following up, coming in from the beginning of the end, picking up the patient, and then going to the end, working with the patient right through, we can definitely see better outcomes than the current model which is in place, which is just random at the moment, unfortunately.
I can't see any questions, Chris. I think everyone is tired, I think, after a long day.
That's perfectly acceptable. No, that's very kind of everybody to come in on the Saturday evening. That's really
That is the main thing. So thank you so much, everyone. Thank you, Nisha, for sharing this, and thank you, Dr. Ashan. And so hopefully we will see in 2 weeks' time for endoscopic vein harvesting.